the more stuff I do for you in healthcare, the more I get paid. And it doesn't matter if that's good stuff, if it's bad stuff. I get better reimbursement if you are sicker.
Welcome back, ladies and gentlemen, to another fabulous episode of the Healthcare Trailblazers podcast. Very happy to be sitting here today with someone very special, Dr. Brown. Dr. Brown is from Northwell Health, which is, I believe, the largest healthcare organization in the state of New York, correct?
That's true. That is true.
Yeah, very, very big. You've seen their logo everywhere. You see them on buses. You see them
on
you see them all
Netflix.
over the
Don't
place.
forget about Netflix.
Where, Netflix?
Yeah, we have 2 shows,
Of course you do.
Lenox Hill and NYC Emergency.
That's really cool.
Mm-hmm.
Okay. They have shows on Netflix, people. Shows. They've got buses, they've got buildings, and they have tremendous doctors such as Dr. Brown, who heads up value-based care initiatives and some really cool things at Northwell. Dr. Brown, thank you so much for sitting with us today.
Thank you so much for having me. I'm really thrilled. This is my favorite topic, so let's get into it.
Well, you came to the right podcast because it is ours as well. So we like to kind of take a trip down memory lane. Tell us about where you grew up and what got you interested in healthcare.
Awesome. So I grew up on the Lower East Side of New York. And for those who don't know the Lower East Side, it's although very fashionable now, back in the day, it was a place where immigrants came, right? It was like sort of Ellis Island, the Lower East Side. It really was this melting pot. We grew up in the projects and, I was sort of the product of just sort of free healthcare and low cost healthcare, and realized at a very early age that was kind of broken, and that sort of the care we were getting as a family and the way we were accessing care wasn't great. So when I had the opportunity to go to Colgate and then go to medical school at Columbia, I knew that whatever I did in medicine was going to be about fixing that. And part of fixing that, even at the time, and this is going back to like Clinton era days, I'm dating myself, unfortunately, was like, we don't have really good foundational primary care. Like we had gotten to this place where everything was being provided as a specialist. So I became a family medicine doctor. I sort of spent a lot of time working in the communities, working for health departments with underserved communities. And it did just kind of keep coming back to these basic core, how do we take good care of people? And when you do that, it costs less. And also got involved in hospice and palliative care in that same way, which is like, if you have really good talk to people, understand what's important to them, maybe what they don't want to do is spend the last, however in some ICU getting care that they don't want. So some do, which is great. That's great. But it starts with this like conversation about how do we keep your health and wellness the best it can be? How do we make sure you are a part of the conversation in your healthcare? And the most important thing is, and then that can't just be vaporware. How are we creating systems of care that really meet your needs? And so I've been with Northwell for the last 9 years, which seems amazing to me. That went by in a flash to really, in a very deliberate way, move us forward in this thing, despite being an amazing system with incredible specialists. How do we really embrace these concepts and succeed in value-based care?
Fantastic. I want to go back to your childhood for a minute. So you're in the projects, and you mentioned that you realized at a certain point that the care that you're receiving, your relationship with healthcare, the way that healthcare was being delivered to your family was broken. Let's talk a little bit about that. Like, what was that realization like, and why? Like, children usually don't have a lot of interaction with healthcare. So what was that?
I can't listen. This is a real interview. I'm like, oh, exciting. So I take it back to this story. I mean, I couldn't have been more than like 8 or 9, and basically, I was like one of these kids who gets like ear infections all the time, and they're incredibly painful, right? Like you are just in terrible pain. I had it on both sides, and I just remember like you have to get there at the crack of dawn. You get there at the crack of dawn, 7 o'clock. You wait online. And then the first line is to just get like your little plastic card. In the old days, you would get like these little plastic cards in the hospital, and that's like what would put like a ditto machine on all your pieces of paper. So you would wait for the plastic card. So that took however many hours. Then you were sort of
hours to get the card.
Oh, hours. And then you wait in line to just get to see the doctor. So then finally, when I got to see the doctor, she was amazing. This was an African American woman who was the doctor. She was so kind and caring. And then she gives you the script, right, for the medicine, but you got to wait online for the free medicine. So now, by the time we're waiting in line for the free medicine, it has been 6, 7 hours. Now we're in the afternoon. We got there first thing in the morning, and it's like 3 in the afternoon. And I remember they had those. If you've ever been on the New York City subway, those like orange and yellow chairs, like that's what they had, were like these plasticky chairs and rows
Of
and rows,
course.
and you're waiting for like the pharmacy to call your name so that you can go up and get your free medicine. And I remember looking over and I saw this old woman, and probably I was a kid, so maybe she was 40. And at the time I was like, oh my gosh, look at this. But no, in my memory, she had hair like mine, gray hair. And I was like, I'm in a lot of pain and this is terrible. And I'm looking over at this woman. And even as a kid, you're like, they're worse off than me. And I was just like, this is not right. This is not right. And as a kid, you don't know that, but you just know that this moment happened to you and you can't shake it. So as I was trying to figure out what I was going to do with all this STEM that I loved, I was like, that I'd like to solve that problem. I'd like to do something for my community. I'd like for that to not be what people are suffering through. So that it's interesting you asked me sort of how. How do you ever want
Yeah, that's a fact. I'm happy I did because that's a great story. Yeah, that really is a great story, and it's amazing how today there's so much more ability with technology. I mean, talking about delivery and shipping, and I think that we have a lot more resources to work with, which is tremendous. But yeah, that does sound tremendously miserable.
Yeah. And then
Wow.
and then you kind of very quickly get to, I spent time obviously in New York City where I did my training and then moved to Florida and worked for the health department there. And that was really an eye opener in terms of kind of value-based care on two fronts. One was, you know, in general, physicians are not trained in this, right? So physicians many aren't familiar with how governmental payers work. So you said, tell me the difference between Medicaid, Medicare, and managed care, just the basics. That is elusive. So when I went to Florida, I was like, I thought all Medicaid was like the same. And so when I got to Florida, I was like, oh, this Medicaid is a different level. You have to be at a different poverty level to get this Medicaid. And what it covers is totally different from what I am used to. And because of those gaps, now there's all these people who, if we don't create, say, a program in diabetes, they're not going to get care, right? It also forced things like public-private partnerships with either, pharmaceutical companies or medical schools to just say, like, how do we start to put things together around quality for people who are
Yeah,
totally uninsured? So that was just a really good lesson for me in terms of like, yeah, there's some gaps on the provider side, there's gaps on the payer side, and certainly there's plenty of gaps as it relates to these populations.
for sure. And so, where'd you go to school? Where'd you go to medical school?
Columbia, PNS.
Columbia. Okay. So coming out of the projects, I'm sure that's also a story. Not everyone that starts in the projects ends up in medical school. So how did you get yourself through school?
Listen, my parents were incredibly smart, incredibly educated. After I was born, my mother went back to school and became a lawyer. My father always had a history. He was a motorcycle mechanic, but had a degree in mathematics. So, we, from day one, it was education, 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 reading, reading, reading. And they're like all parents, like, be a doctor. So,
Right.
that was good life advice. And since I loved the sciences, it all came together.
Incredible. So it sounds like early on, given those formative experiences that you had really in your childhood, um, it sounds like you caught on to the concept of value-based care pretty early on. And even now, it's just starting to gain some real traction in the country. And you're talking about quite a number of years ago. Um, how did that realization start coming about? And at what point did you start thinking about like reimbursement models and aligning financial incentive with patient care instead of patient instead, like outcomes of care instead of instances of sickness?
Yeah, and I give a lot of credit to, when I was looking to say like, well, what kind of doctor you're going to be, because when you go to Columbia, it's not like easy, but you do have lots of options, right? In terms of whether you're going to be a specialist or a surgeon. And the only specialty that was speaking to me in terms of like, what are we doing for the communities? What are we doing across populations was family medicine. Because as part of that training, you had to look at people comprehensively. As part of that training, you actually couldn't get out of the residency program without a community-based project where you were looking at populations and how to improve the health. Also, sort of foundationally, and again, this was family medicine was happening at a time, right, at being established as a specialty when it was becoming very clear that the total spend was going up and up, and the governmental share of that was going up and up, and that we had this trend of people getting lots and lots of care, right, through specialty care. So it was in the training a focus on, do they need 50 tests? There's 1,000 drugs here. Which ones are the right ones? There is a behavioral health component here that you need to address because it is driving some of these other things that are important. So I do give a lot of credit to just the training really speaking to why I went into healthcare, which was to think about the systems, and then also this idea of like it's not just good to spend lots of money and do a million MRIs instead of managing and dealing with the person in a holistic way.
Right. Now, for many of our listeners are not doctors or people that are involved, or a lot of doctors that still don't know what value-based care is. So before we kind of get into the weeds with value-based care and how you're going about it at Northwell, to the complete novice, what does value-based care mean to you in deference to the typical fee-for-service reality?
Yeah. So value-based care is, and it's hard to do that without saying like where we are now is.
So do that.
Yeah.
You can start with where we are now.
Where we are now as a health system, as a country, is the more stuff I do for you in healthcare, the more I get paid. And it doesn't matter if that's good stuff, if it's bad stuff, I get better reimbursement if you are sicker. So that doesn't mean doctors don't want to do the right things. It just means that there's no money to invest in a system to keep you better because I do better, like the hospitals do better. Everybody does better if you're sick. So that's where we are now. It's just you do more stuff, you get more money. You do more complicated stuff, you get more money, whether that stuff is needed or it's not needed. What value-based care is saying is you are going to get paid based on the quality of the stuff you do. And toward that end, sort of value-based models invest in the things that are likely to get a clinical outcome that is good, because in value-based care, you can't get paid unless the quality outcome is there, and where whatever you invested in the thing, you're seeing that back in terms of how you get paid. So it's everything from like the programs we do around readmissions, right? So if I hit a certain readmission, keep those patients from being readmitted, which is really like suffering, right? When you leave the hospital, do you want to have a infection complication and need to come back and get readmitted? No. But in a traditional model, I get paid both ways. I get paid both ways. I get paid for the initial surgery and then for the infection. But in value-based care, it's like, no. Let's make sure you have your antibiotic. Let's make sure you have access to your follow-up appointment. Let's make sure the minute you have a fever, somebody's on the phone so we can maybe handle this for you at home. It is about the preventing of human suffering, which then is reflected in unwanted, what we call unwanted and really low value spend, which are things like readmissions, or you didn't need to go to the ED because your eardrum, to take it back to my childhood story, was ruptured because we handled that for you right away. We got you in early. We got you sorted out. So there's no ED visit, which is unwanted suffering, and you're better, right? Like you got timely care, you got timely treatment, and that I would get paid for that. That instead of just getting paid because you're really sick, that I am getting paid for the value of the care I'm providing. And that's what it is.
Yeah, and to people people listening and watching, I mean, the simplest way to understand how the incentive actually works is, I think, the most extreme when so there's a different type of contract, and jump in if I'm saying something off, but there's a different type of contract called a risk-based contract, and that's where essentially instead of getting paid per instance of care being provided, which is like Dr. Brown talked about in fee for service, I operate, I get paid, then an infection comes up, I get paid again. The difference is saying, okay, let's create a benchmark, a baseline of what we think it should cost for the totality of care for this patient. We're going to pay that, but now the person that accepts the money, which in this case is the healthcare provider, typically an organization, is now responsible for that entire patient's healthcare. And therefore, the incentive shifts to becoming, how do I make this patient, how do I manage this patient so well so that they stop getting sick and that they stop coming back in the hospital? Because if they end up back in the hospital, I'm incurring that bill.
That's
And I think that the most extreme version of total risk is the easiest to understand. I'm actually fuzzy on the middle. Is there middle ground? And what does that look like at Northwell?
Yeah, so if you look at sort of CMS and CMMI, which is the Center for Medicare and Medicaid Innovation, they really there is a progression of value-based, right? And I'd say like the lowest level, right? So one basic level is what we would just call pay for performance on quality. So you take the example of diabetes. Part of the contract or any contract that you have is tied up in how well controlled patients have their diabetes, meaning you're not really at full risk, but if you hit certain quality thresholds, there's like an incentive there. And then there's the middle ground, which is
In addition to your fee for service.
in addition to the fee for service, right? Because what they're acknowledging is just managing diabetes well has value to the patient, right? So they don't get amputations, they don't get these, awful hospitalizations with hyperosmolar coma. So they're willing to incentivize those things, and that's across also the managed Medicare plans. In the middle ground, you have sort of this, sort of these penalty and mandatory programs that are at risk. So when we talk about readmissions, they sort of say, okay, the whole country is at about 18% readmissions in certain conditions. You're at 20%. Guess what? You're getting penalized. So you need to get to be at least average, right? We're not saying be the best, but you have to kind of get to some average place where it seems like you're treating a pneumonia patient as well as the hospital next door. And if you're not, and those pay your patients for the risk, right? So there's all risk adjusted. So it's not like they're not expecting you, a 20-year-old to have the same risk as an 80-year-old, but they're saying for the same risk, we're going to penalize you if you're doing a poor job. And that's risk. Like, we don't want to take that risk on our total Medicare business, but we have to. Another example of that is the CJR program, which is the Comprehensive Joint Replacement Program. That is mandatory for many metropolitan areas. And that's let's say if you have your hip replaced and you're a Medicare beneficiary, it's a total cost of care for that episode. Not everything, but if you get your hip replaced, the hospital is on the hook if you end up in a rehab for 100 days, if you get readmitted, if that joint gets infected.
Almost like having a warranty on your
It is like a warranty on the hip. So that's sort of middle ground where you're not taking risk on everything, but there's like some mandatory stuff. And then the full stuff, which is like the ACO kind of programs where you're saying, okay, we're going to take full capitated risk on a population. So whether it's an ACO and a risk track or things like, the what's now called ACO REACH, where you say, like, we're going to actually treat you, and it's really exciting, right? So CMS saying, listen, we're going to treat you like almost a payer, and we're going to give you premium, right? So that you can get these great nurses who are going to talk to people and nutritionists who are going to help people with their diet. And maybe you're going to cover things that Medicare maybe wouldn't otherwise cover, like lift chairs and assistive devices and transportation to your appointments and groceries, right? Basic stuff. And in that way, we're going to give you some upfront money to do this work, really take good care of people so that over the year, the total cost is down.
Yeah. And it's so amazing because I think there, other things that seem like buzzwords around like social determinants of health and population health management and all these various things that seem like added on, burdens for hospitals and other healthcare providers. I think when you start talking about value-based care, instead of burdens, these things become the exact things that you are specifically incentivized to start looking at. Because if my sole objective is keep patient healthy, then it's in my best interest to start thinking and start saying, okay, where are you growing up? What kind of resources do you have? What does your community look like? Those things they don't become, all right, guys, we got to go to a seminar now. It's, and think about this. It's, if I'm trying to think how to keep this patient healthy, these are the natural thought processes that are going to occur.
Yeah, and it's so, and I kind of bring it back to the IHI has a framework called the quintuple aim, and it's all these things we're talking about. And one of the other things, in addition to equity and diversity in outcomes, it's this business of physician burnout. And one of I still see patients, and it is the greatest. And when you can see patients and you're not just churning them, right? It's not about like, can I just see 50 today? It's like, how do I take care of this person right in front of me and just have that relationship? It is so fulfilling. And I think it's value-based care is an opportunity to really combat some of that physician burnout. Because to your point, it's like, yeah, we don't need to go to a conference to ask our patient, like, do you have food in your fridge? And then to have the resources to deal with it, because that's part of the burnout and part of the challenge is like doctors, it's hard to ask about depression and do you have food and is there a intimate partner violence situation here if you feel like there's no resources to deal with this. I don't have any resources to deal with this, and value-based care becomes the opportunity to really direct kind of help support services for the provider, right? Also for the provider and for the patient. So I just want to mention that.
Yeah. So when I talk about value-based care to people that are completely uninvolved, even in healthcare, just random people, I think there's two common objections that people give me. Not objections, but like, hey, did you think about this? And so I'd love to hear your thoughts on it. Thing number one is, wait a second, if I start getting paid based on the positive health outcomes of my patients, won't that incentivize me to stop taking sick patients or fire my patients?
Yeah.
What are your thoughts?
So that does come up. I will say that comes up a lot, and I've gotten that in sort of the surgical space. And when we've looked at this, we don't see any of that, meaning nobody's saying no to patients. So there is a little bit of like, this is the theoretical zone of like, what if, right? Which is like, well, let's like look at the data and see if we have any indication that that is what is happening. And for Northwell, we don't have any indication that that's happening.
But are there no regulatory safeguards to stop?
Yeah, first of all, right, exactly. I mean, you can't abandon your patients, right? But you can, I mean, in all practical, you can sort of say, these are the insurances I'm taking and these are the insurances I'm not taking. And what I would say to that is, we already have that, right? Try to find a dermatologist who's taking any insurance. Try to find a psychiatrist who takes anything. So this is not a problem of value-based care. This is a problem of like, how do we have compensation for providers such that they are taking insurance? But the other sort of part about that in terms of sicker patients versus not sick patients is, in fact, that the opportunity is sitting often with the sick patient. Because when you think about value-based care, and like you said the word, the baseline, what anyone would expect that person to,
that's the answer,
right?
Yeah, I like where you're going.
Hey, like if you're in my value-based portfolio, it's like you're going to be fine. They expect you to spend nothing and you will spend nothing. So there's nothing for me to do for you. But if you are an older senior person who is spending a lot of time in the emergency room, spending a lot of time in the hospital, now that sick person, I've got something to work with there. I can do home visits and I can have a nurse come visit you and I can make sure you have food and I can make sure all these things so that you aren't suffering, so that you are not sort of doing this spend. So the sicker the patient, kind of that's where the chances really are, because you've got 10% of the population spending 80% of the dollars.
What you just said is genius, and that's the real answer. That's the answer.
I'm glad I had the right answer, because I would have.
No. Well, I don't know. I'm listening to you, and I'm learning. I'm not. It's not like I was looking for a specific answer, but listening to the two things you said, I think that the fact that it's not happening yet is not an indication that it will not happen. The second thing that you said is brilliant, which is it's actually a stupid question, because it would be like coming to a hedge fund and saying, why aren't you just investing in Facebook and Google?
Right. Exactly.
And the answer is because there's no opportunity there. The opportunity is in all the low-lying investments, because we feel like we can come in, provide some value, and inject some profits into said company, and that's how it is with
exactly. You nailed it.
This is why you're the smart one. Nice. Okay, cool. The second thing that I come across, which instead of asking for your thoughts, I'll make it a specific question. So the other thing is that there's potential for just like there's potential for fraud on the one side, there's potential for fraud on the value-based care side, which is that you basically will start having, once you move the financial incentive to complex patients, essentially, you're going to start having providers overcoding their populations to make them look sicker than they actually are. If you have any general thoughts on it, I still would love to hear, but I think the answer is probably just around education. And then, so the specific question would be, what does education look like as far as refiguring the mind to like code correctly and being compliant? Maybe you have general thoughts on it.
Yeah, I mean, I'll actually go very specific, and say like we have fraud and abuse on both sides, and this is where the OIG has to keep everybody honest, because you just have some bad actors out there, and there is like code inflation, and CMS is doing some work around changing the codes. And what I always say across all of these different value-based programs ever is, this cannot be a like documentation game, because CMS, whatever you think, however smart you think you're going to be, they already thought of that. They already have enough data to understand what you're doing. Don't do this. It has to be based on the clinical thing you're hoping to achieve. So in terms of our kind of coding approach, it's like the only reason, right, everything gets documented, whether it's an HCC score or not. And more than that, everything gets treated. So this concept of like, no, I'm just going to discover this disease so I can put it in the note. It's like, no. That's not the point. The point of this, so if we're talking about education, is you're really educating your providers. Like, this is not about documenting the thing. It's about treating that condition and understanding, hey, you have a really sick diabetic. They're not just diabetes NOS. Like, you have a diabetic who already has neuropathy. They're likely to have nephropathy. Did you do a urine screening to see if they have kidney disease? That's what the point is. And when you educate in that way and you don't try to game the system, everybody wins. You win because you really are knowing your patients. And whether it's an HCC score or not, right? Maybe it's just hypertension, but guess what? Treat it. And then they don't end up in the ED with blood pressure out of control and headaches and all these other things that are terrible for people.
Yeah.
So that's what you got to do. That's the only way.
Tremendous. Okay, so let's shift to Northwell for a second. We've had one other person. We talk obviously all the time about value-based care, but I think there's one other person that's been on the podcast, Dr. David Page. Shout out. He's the CEO. Well, he retired, but former CEO of St. Luke's Health System, and he came into a complete fee-for-service system, and from the inside transformed a third of their $3 billion in revenue into value-based care, which was a tremendous thing. And I think that you seem to be in a very similar position, where you're heading up value-based care from Northwell. Northwell is a massive organization. Talk us through some of the dynamics of coming into a current reality and trying to shift from the inside out, which is, I think, tremendously more complex than starting a value-based care organization.
It is. Thank you for that. Thank you for that shout out, because I think that's the other thing. Both things can be true, which is Northwell is doing really well providing fee-for-service, care for people. And it's everything you would think. It's transplants, it's cardiothoracic surgery, it's bypasses, it's these hip and knee replacements, and doing an incredible job. And just by the virtue of the quality of the care, that is all good. So for me, it is not about taking the current business and shifting it to something else. It's adding to the current portfolio and saying like, oh no, yeah, we're going to keep doing amazing cancer care and amazing orthopedic care and neurosurgical care and all these things and transplants. And also, we are going to have populations where we're not at risk for them. And here it makes sense for us to just take exquisite care of them. And then, from this governmental perspective, say like, and if we take really good care of them, how do we realize more of those dollars? So it's an opportunity actually to do both. And that's really the approach we're taking.
Interesting. So you have the benefit of coming in with a whole lot of data, and you can segment what parts would benefit most from value-based care arrangements versus what parts would actually benefit most from your
staying at fee for service, right? And that is the opportunity. And I think one of the secrets of healthcare that people may or may not be aware of is, the commercial payers, so like your private insurers, are in some ways subsidizing the governmental payers, because some of those, what a doc, like, for some plans, and this isn't Northwell specific, it's just like nationwide, we just looked at the nation. So like, what does maybe Medicaid pay for a visit? And a patient might be like, oh, I'm sure the doctor gets like $150 or $100 for that. Whereas Medicaid maybe pays $25 or $30. So, and just inherently people are like, can you do this for 30 hours? And the answer is like, no. But so we need to have sort of a mix of things. But if I'm at total cost of care on that Medicaid life, right? And say like, hey, like I'm going to really keep you healthy. I'm going to make sure you have groceries. I'm going to, because built into the whole thing is the fact that you're going to end up in the ED for different things that you don't need to. And there's an approximation of about 30%, sometimes north of that, of ED, emergency department utilization, is avoidable. So if I can avoid even some part of that ED and then share in that saving, then now the $30 becomes $60. And now that suddenly makes sense. So that's what we're trying to do, is find on that continuum of just getting paid for quality in addition to fee for service, getting sort of making sure where we have a penalty, we're optimizing, and then where we are at risk, making sure that we're performing in those risk pools.
Tremendous. Let's talk about, so we've talked about kind of from the payer perspective, from the Northwell's perspective. Let's talk about the patient experience perspective. What are some practical things that you've implemented, some programs, maybe some preventive programs that you've implemented from the, like, let's look at it from the lens of the patient. What does the experience being a value-based care patient, so to speak, in Northwell look in contrast to a fee-for-service patient?
Yeah, so we have invested pretty heavily in that patient experience navigation support zone. And really what that looks like is it's overcoming two fundamental flaws in the healthcare system. One is access. So instead of sort of sitting back and waiting for patients to make the right, like, so healthcare in general, you sit back and you're like, well, the patients will call me to make an appointment. The patients will show up in the hospital. It becomes about an outreach function where we are reaching out to people and saying, right, and this is not, none of this is rocket science, and everybody on the who's listening in doing, they're like, she's just talking about the basic. But when you're a beneficiary and somebody calls you and says, hey, you're kind of missing your mammogram, how do I help you get a colorectal screening? It looks like you haven't had your eye exam. And they're like, yeah, I have not had time to do that, and I can't even get that appointment, right? Access is so bad. And it's like, no, I have the back number. I'm getting you in. Yep. I'm getting you in. I'm going to hand hold you. I'm going to concierge you right into timely care. I'm going to give you a 24/7 number that is to real clinical care, where you're not going to be holding, you're not going to be waiting or trying to wait for some callback. You're going to get to a nurse right away. It is about also provision of services in the community, right? I'm not always going to ask you to come to my building. I'm going to, because you're in this value-based thing, if you get sick, I'm going to send somebody to your house. If you end up in the hospital, I'm going to follow up and make sure you got your meds, you understand your discharge, you have a follow-up. Again, back to access. Like, I'm going to get that doc on the phone and say like, hey, they said they needed cardiology in a week, not 6 weeks. Can we get them in? And I tell you, 100% of the time, I have not once, and I've been doing this for 9 years, had a specialist who had a patient leaving the hospital where they were like, I can't fit them in. The doctors don't know they just got out of the hospital. So they're like, yeah, my next available. It's 6 weeks. Like, no. They were in the, oh yeah, send them in. So it becomes about making those connections. And that's the experience of patients who are in these programs.
Yeah, that's tremendous. Yeah, it's amazing how just a shift in incentive structure trickles all the way down to a shift in mindset and a shift in mode of action. But there's got to be also, and I want to give credit to you guys for more than just that, because if your providers are actually acting like that, then that's a culture thing as well. And so what is the kind of culture in at Northwell that creates the type of doctor that actually cares, and they're about to pack up and go home, but they make that extra couple minutes and they make that time?
Yeah, well, I mean, I give tremendous credit to our leadership, Michael Dowling, Jill Kalman, Dr. Jill Kalman, just amazing cardiologist who's our chief medical officer, in establishing like, what are we all doing here? And like, getting back to this other point, it's like, it's not about saying like everybody has to be in value and all these expensive things are bad. It's like, No, no, no. But how is the patient experiencing what it is to be a Northwell patient? The other thing that we have at Northwell that I think is unique, but probably other systems are like, why is she saying that's unique? Which is we spend a lot of time becoming a team together. So it is about this patient, and there's no doctor ever who's like, "Yeah, I don't care if my patient gets readmitted." No doctor wants that. Doctors want their patients to be well, and also it's about saying like, "Hey, I go by Xena. That's Xena's team. They're calling me. Like, yes, of course. Like, let's let them in." So there's a lot of focus at Northwell on us as healthcare providers, interdisciplinary, really coming together. And that's an organizational expectation. And one of the things where if you are not on the team, that is sort of culturally problematic here.
Amazing. Dr. Brown, we could go on for hours and hours. It really is a pleasure, but I know we're coming up on time. If there is, I mean, you're obviously doing tremendous things at Northwell. If you you finish your career, a long, healthy, tremendous career, and you look back and you've accomplished one highlight thing that you still haven't yet done today, what is that thing?
Oh, that's a good one. Probably I should have this like, I should have this. This should be like a canned answer for me.
Well, I feel like I'll be honest, it's not such a fair question because it seems like you're executing on all of this. So I don't know if there's an additional thing that you will have done,
I will
but maybe
say
to a greater extent.
I am lucky. I do feel like I'm living my dream job. I do feel like that. This is what I ever said I wanted to do in healthcare, and Northwell is really giving me space to do that. I think if I had to look back, like the thing I really want to do, if you're like, "Ooh, what's your secret desire?" is I would love to be able to say this whole region that is under the umbrella of Northwell, these patients that we take care of, they're the most healthy they could be. And that the way we're doing that and the way we're approaching that is obvious, and some future state of healthcare where it's like we're not in competition with our other healthcare providers, but we are just raising up the health of communities and saying like this neighborhood, this zip code, there's no difference. Everybody's getting the same care, and I think we're getting there. I think we're tending there, and if I can be part of what gets us there, that I would look back on my career and feel like it was a career well.
Amazing. And I'm sure you will. And I'm sure one day you're going to accidentally walk into the facility and see a young girl from the projects, and you're gonna watch her go right from the doctor's room, pick up her med, get it ordered, delivered at her house, and she'll be in because all the incentives are correctly aligned, and you guys have created the right infrastructure. So tremendous kudos to you, and I'm excited to watch your continued work at Northwell.
Thank you. Thank you. It's been wonderful. Thank you so much for having me.
Absolutely.